So I guess we can start the webinar. Good afternoon, everyone. A warm welcome to all attendees, all healthcare professionals and organizations joining today. We are delighted to have you join us. We are all set for an engaging webinar today to delve into today's topic of focus, which is leading population health in a new era. It's a pleasure to be your host today. My name is Ricardo. I'm a student recruitment advisor at RCSI Online. Before we commence, I would like to extend my sincere appreciation to our speakers today, all the participants and organizers who have contributed their time, their knowledge and passion to make this webinar possible. So as we get started, I would like to firstly run through some housekeeping. Your microphones will be muted throughout the webinar. We welcome you to input any questions you have into the Q&A box, and then we will answer your questions at the end of the session. It's also worth noting that today's session will be recorded, so if you would like a recording to review or to share with your colleagues, it will be emailed to you after the session. It will also be made available on our YouTube channel. And now I'm delighted to finally introduce you to today's speakers. We have Professor Edward Gregg, Head of School of Population Health at RCSI. We have Dr. Sarah, Director of Academic Programs, School of Population Health at RCSI. We have Dr. Emer, Consultant Trauma and Ortho Geriatrician at Cork University Hospital. And finally, Tony Canavan, Regional Executive Officer at HSE. Without any further ado, I would like to give the floor to Professor Edward Gregg, as he will be giving us an introduction. I really hope you enjoy the webinar and feel free to leave any questions so we can answer them at the end. Professor Edward, the floor is yours now.
Thank you, Ricardo. I'd like to welcome everyone. My name's Ed Gregg. I'm the head of the School of Population Health. I'd like to also echo thanks for the speakers and for all of you for attending. The School of Population Health now, we launched a year and a half ago around goals of, really three goals of improving, of doing cutting edge multidisciplinary research to population health research to guide the decisions that are made for population health problems, to build synergistic collaborations that help build the infrastructure for population health, but also to educate programs that meet the workforce needs of the future. So you're going to hear a bit more about our upcoming master's program. But what I'd like to do really is sort of set the stage for this discussion just with a couple opening comments about our challenges and our opportunities in population health. So, you know, the idea of a new school for population health partly came out of and was coincident with the biggest pandemic that any of us can remember. But I think, as you all probably know, the challenges that we have in population health were really present long before that. And they're really a combination of both demands on us, but also opportunities. And the big demands are that the problems that we confront are changing all of the time. For us right now, chronic diseases, partly because of the reduction in mortalities that we've seen in populations virtually everywhere for decades now, is actually putting a new burden of diversifying morbidity, chronic conditions upon us. So that's one of the big challenges and demands. At the same time, the science for population health has really been evolving very rapidly with new potential, speed of execution, dissemination of research. We have proliferation of data systems, our laboratories for population health, the way we use real world data and health systems data is now playing a bigger role. We have dramatic advances in computing and statistics and methods. And all of these are actually feeding a diversification of the disciplines that we have in population health. So that's really the demand and the opportunity in front of us. And next slide, please, Ricardo. Thank you. So, but if we step back and look at really what our fundamental challenges and what we try to do in population health is that when we have this charge of confronting many problems that have multi-layered determinants and risk factors that require multiple avenues of action, we have to look for certain efficiencies. And the ways we often look for those efficiencies is looking for levers, structural and policy levers that can influence lots of risk and lots of people and lots of conditions efficiently with one swoop. So we look for synergistic interventions, for example, that can influence multiple risk factors, things like integrated care, the way we set up our care, and we look to actually validate these and evaluate our effectiveness progressively with real world data. And this is really also part of our focus of the master's program that you'll hear about is that, and the theme of this webinar is about leading in population health. And what we see that leadership, the way we see it is that leadership really requires leadership across a spectrum of understanding through diverse science, making decisions through strong evidence base, and then ultimately acting through really strong partnerships and collaborations. So that's sort of the backdrop and our charge into the future. And I'm really looking forward to our discussions in some more specific topics in chronic conditions here today. Sarah, I think you're up next, am I right? So I welcome you all, thank you, and I'll hand it to my colleague Sarah Berry now.
Thanks very much, Ed. Appreciate that, and just delighted to be here in this conversation today and host it, and also just to welcome you all to the webinar from my perspective. Ricardo, maybe we could have the next slide. So just on the basis of what Ed has said as a general introduction, I just want to kind of land this a little bit more in the Irish context. We have a policy intent for population-based health and social care system under the rubric of Sláintecare, which I'm sure will be well aware of. And it's the logic, at least in principle, driving our health system reform programme at the moment. And whilst Ed has highlighted some of the key drivers of system reform that's relevant internationally as well as international context, we all know well this kind of demographic bulge that I've highlighted there, and it tells the story, obviously, of the success of living longer, but also that along with that, many of us are living, if you like, less well with chronic disease, as Ed has mentioned, frailty, and increasingly complex care needs. And this is a key driver of our need for reform in the Irish context as well as internationally. And our emerging new health regions are an organisational response to this changing profile of how to deliver health and social care services. But they come with a health warning, I think, in terms of the path dependency that we live with. And I'll come back to that in a minute. Now, Tony, one of our speakers today, Tony will tell us more about progress on this front, I'm sure. But just to note that in practice, this means a lot of change at several system levels as the regions and the health areas and the community health networks, or CHNs, all continue their work of forming and norming. And at this point, I just want to highlight that getting the structures right really matters. So I'm a believer, but we can't underestimate the challenges involved in getting to the performing stages. And so maybe, Ricardo, you could give me the next slide, please. Thank you. So there are significant challenges in moving to a population-based approach to how we deliver our services, and more importantly, generate population health. It's a challenging path because it involves a lot of change in terms of governance, and our speakers are living with that at the moment, but also in terms of the technical skills and the capacity for things like population-based needs assessment, resource allocation, information synthesis and decision support, all those kind of technical things that are necessary to make this structure actually work in practice. But importantly, it's also a big challenge in terms of the established ways of thinking and our culturally embedded ways of working. And I've highlighted some of these a little bit. So, for example, we consistently think in terms of services, you know, and organise on a services-based line, rather than exploring the true implications of the integrated care model that sits with the population health approach that Sláintecare advocates. And there's some important learning to be gained here in many ways, but I've just, in my own mind, I was thinking about what's happening with the Enhanced Community Care Programme, for example, and we might talk about that a little bit more. An old challenge, of course, is the deeply, embedded institutional silo kind of approach, and it's at times reinforced by how we go about driving systemic reform. And unfortunately, siloed services drive fragmented care for people. And from a population perspective, they're a barrier to better general population health and well-being. And I believe contribute, if you kind of track back to problems such as longer wait times and access to care challenges. And in all of this, we believe that addressing some of the chronic challenges we face includes increasing population health literacy, thinking again about how we can connect and make best advantage of our public health expertise. But it also means bringing in new agents and actors and advocates into the population health space. And I think this includes people working within the health and social care system at all levels, but also new actors working outside the formal system, which is why I've highlighted here in the slide taking the ecosystemic view, so that the whole notion of something like place-based population health hinges on the idea that health generation is the work of a whole community and means enabling people without voice to become more engaged in the service of health equity. So without too much further ado, how do we unlearn some established thinking and behaving and shift our thinking and our imagination as well as our culture to strengthen what we are doing in terms of structures and systems? And with that in mind, I'm going to kind of shift the focus into our fireside chat space of the webinar this afternoon. And just to welcome again Emer and Tony, and how much I appreciate you taking the time to join us this afternoon. So we don't have a fire, Emer, Tony, and we're not really beside each other, but through the magnificence of technology, we can actually have an interesting chat. So Emer, I'm going to start with you, if you don't mind. And I'm just going to sort of, as a starter, pretend to get us into this from your role and your insight, particular insight you bring, your perspective. How do you think, how important for you is the population health approach? And maybe if you could, what does it mean in practical terms?
Yes, and thank you, Sarah, for the invitation. I suppose at the outset, I need to make a disclosure that I'm not an expert in population health, but I probably am an expert in what I need to unlearn and learn again. So I think that was the reason for inviting me today. So thank you. I do believe, Sarah, that we're really at a real critical point, kind of like in the Irish healthcare system at the moment. So as you say, you alluded to, we have the policy direction for population health. And certainly, and Tony will talk about the setting up of the regions and all the structures and that. But I do think from a clinical point of view, from my clinical role, kind of like working every day with kind of older adults, but also in my kind of national leadership role, the role that I was trained in, and the majority of people and clinical people who joined the call today, has been in the old way of delivering healthcare. So it has been largely dealing with sick people, and to make them better and to kind of like leave, keep them at home. Or to get home again, and that kind of served its purpose for the populations that we were looking after before. So when we were really involved, I think, as clinicians in improving life expectancy, and that was really kind of the role that we played. But I think that has changed now, and now we have a population that are living longer but have multiple needs across many domains, and the current healthcare system isn't fit for purpose to look after that cohort of people. So we need to find a new way of approaching this. And this is why this is about this is why the population health approach needs to be become kind of routine part of our practice. But I think what we've learned over the past is that we weren't trained. I didn't receive any training in population health and what that meant and how I could apply the principles to the work that I do every day. You know, so I have a certain level and understanding of it just through my leadership roles and just been involved in conversations kind of in the past couple of years. But I really think it's a huge kind of deficit that people don't have and maybe aren't aware that they don't have those skills at the moment. So I think what we really need to do is to, you know, for people to have, in order to deliver population health, we need to have the skills and the training in order to do that. Kind of in a similar way, I think, you know, people who have gone into quality improvement that thought that you could just simply just do it all the time and, you know, have an idea and improve things. I suppose people have quickly learned that that doesn't work out so well, that you need to have the knowledge and skills for that. So a lot of people have got into that space, and population health is the same. So there's the science, as Ed has talked about, and there's all the principles about implementing it that you need to have in order to kind of like be able to kind of clinically work kind of going forwards. And I do think at some level that we thought that, you know, integrating care and population health would come almost intuitively to us as clinicians, that it wouldn't be so hard or it wouldn't be, you know, so challenging for us. But I think what we've learned over the past couple of years that it is really hard and it is really challenging, and we do need a new set of skills in order to be able to implement it to serve the people, to serve the populations, in Ireland.
Thanks, Emer. That's a great start for Jen and sets excellent context for us. And I'm going to turn to you, Tony, from that more management perspective within the service, and just ask you the same question. Given your role in Insight and what you're currently involved in, how important is the population health approach, and what are the practical implications from your perspective?
Yeah, thanks, Sarah, and thanks for involving me as well in the discussion. So, I suppose in a very short answer, I actually think it's the population health approach is actually really important. It's important to the success of the regions, but I'll kind of explain a little bit about what I mean by that. You know, I've just started in this role since the beginning of March, and I'm hoping to be around for about 5 years or thereabouts. You know, so hopefully in that time, you know, I will have been involved or led out on the rollout of the regionalisation of our health service, and I think that's really important for sure. I'd also like to think that, you know, that new structure, that regionalised approach then will help us to really chase down and tackle some of the big issues that we're very familiar with around access, you know, access to our emergency departments, our off-waiting lists on the hospital side, or even access to our cancer services, but also on the community side. You know, we've seen the issues that have arisen in the mental health services around access, and also around our primary care and disability services as well. So, you know, really, I would like to have delivered quite significantly on all of those issues as well, but fundamentally, they're big issues and they're really important that we deal with them. But fundamentally, you know, unless we have contributed to the overall health of the population, it doesn't really matter that much. So I would like that at the end of my 5 years, that when I look back, that in some way we can measure and we can say objectively that the health of the population is better than it was when we started. Now, that's a very broad statement, and I think the practical issue around that is how do you define that and how do you tie that down? And more importantly, I suppose, how do we as managers work within the service, how do we agree amongst ourselves what's important to measure and what's important to deliver on, and how do we do that with the population that we're serving? In other words, we're not deciding for the communities that we serve, this is what you will get and this is what will be good for you, but we're agreeing that and agreeing that in front of the populations that we're working with.
Yeah, Tony, that's great. And I might just stick with you for a minute, because you've mentioned sort of 5-year term. And I think in terms of the sort of slow change that structural change is and everything that it brings, that's not a bad interim marker in the sand, as to kind of get a sense of what is difference in effect. And maybe, you know, you highlight there, you know, the need to measure differently, the need to be clear in our definitions, and then really importantly, the agreement right across. And I think this is one of the key words, and maybe to throw trust there into the mix across the kind of the anti-siloization that we know is so prominent in the way we think. Could you kind of dig into that a little bit, like practically speaking, in terms of population health outcomes and the measures that might drive that? How are you thinking in terms of the region for the West Northwest?
Yeah,
what difference it'll make?
Yeah, so firstly, I suppose, you know, we often think that we're special and that we've come up with this problem all of our own, and that, but the truth is that, you know, countries across the world have experienced this issue and have already started tackling it. So I think there's work there for us to do, and just looking at what has happened in other parts of the world and how they've approached it. From my point of view, the way I think about it, and it literally is just, I suppose, if Emer describes herself as not being an expert, I can guarantee I'm way down that scale as well in terms of not being expert. But I do think that from a management point of view, we need to approach it in discrete parts. So looking at it from the point of view of our cancer services and cancer outcomes, I think is a good place to start. Looking at our mental health services, and again, you know, what we're looking to achieve in terms of outcomes for patients of our mental health service, I think is another a good area to look at. And perhaps also there's even though 5 years is a relatively short time frame, perhaps there's something we could do on the women and children's side as well, particularly around maternity services. But all of those are kind of Tony Canavan shooting from the hip, and they are largely based on my own history, you know. So you know, when I look back on my own career and I look back on you know, various service changes that I've been involved with that I think have had an impact on population health, that's what I'm referring to, you know. But I think there's a whole range of different other measures that we should be looking at as well.
Thanks, Tony. Emer, if I could kind of pivot that back to you in terms of the idea of, you know, kind of eating the elephant lump by lump, you know, the discrete parts sort of approach. I kind of get that, but I also kind of a slight little alarm builds around the challenges around integrated care and what that means. I mean, from your clinical perspective, and obviously you're dealing with that, you know, critical population within this space, any thoughts on how do we move forward from an implementation and the difference it will make for those discrete populations as Tony has highlighted them?
Yeah, Sarah, I think a critical part of this, you know, and moving forwards will be the engagement, not the engagement, and I actually think that's even superficial in itself. But I suppose when I kind of think of, let's say, where I'd like to be in 5 years' time, or kind of what I would like to influence from my position in 5 years' time, would be how we would involve, you know, people of all populations, you know, those high-risk populations in need, vulnerable populations, you know, how they are being incorporated into the structures, so they're leading on the services that are needed. So I think kind of heretofore, where we talk about patient and public involvement, it's usually just a tick box really exercise, you know. And I think we really need to get into that meaningful level of really viewing these people in, you know, in whatever population, as they are the experts in what they want from their health, and they're experts in the way they want to live their lives, and to really to get that will inform then how we plan and deliver services and how we get the outputs and the outcomes that we need. And I don't think we have been, you know, good enough at that kind of up until now. Like, we've made kind of, you know, kind of largely kind of paternalistic kind of responses to that, but I really do think we need to get into that space. So it will be, so what I'd like to see is that you'd almost have an executive of like the people who are using the service like at the table, and that all of us as leaders or clinicians are kind of sitting kind of outside that table, actually kind of delivering what is being kind of mandated from the table. So that's I think that's really important. And in terms of outcomes and outputs, then we need to actually then get to the level of like what outcomes matter to people, you know, and what do they kind of expect and want from the health service. Because again, I think as clinicians, we tend to over-prescribe and sometimes kind of over-egg what we think is kind of wanted and needed. And in actual fact, when you have the discussions and those real discussions about what patients want and need, you know, you're usually ending up going kind of in a different direction and looking for different outcomes and outputs. So kind of living or dying isn't the output or the outcome we want anymore. People are living with chronic diseases, so the outcomes that they want are wholly different to what they were from before.
Yeah, thanks. I mean, you both highlighted, I suppose, some of those key mechanisms that's going to drive this shift left to population health approach, which are, you know, defining the right measures, you know, really thinking in terms of, you know, I suppose managing and delivering for changed outcomes. But I just want to focus for a minute on another key mechanism that's at the heart of this change in terms of the structures, which is the governance. And I suppose maybe to both of you in different perspectives. You, Emer, you know, obviously you're in kind of based in, but you have a national perspective, one part of the country, Tony in the other. In terms of that clinical governance and that linking up of, you know, the various different care domains that we have, where do you see the real opportunities, and are there particular challenges at the moment that you see? And I've opened that up to either of you who'd like to respond.
I might go first, Sarah.
Yeah, okay, Emer, go for it.
Well, I do think kind of the clinical leadership kind of at all levels, you know, is critical. And I think it is about, and somebody's asked a question about kind of the leadership, but I do think that's kind of fundamental to this kind of going forward. And I think what's going to be the challenge is about how we kind of diversify that leadership, you know, across all the different kind of professions that are working in the healthcare service. And not even within the healthcare service, but to bring in leadership, you know, from organisations that we work with outside, you know, the non-statutory services, you know, and what I would think about it is that, again, it would be to look at the continuum of services that we have available, which are largely a lot of HSE kind of services, but to look at all the services kind of outside of that, kind of within the communities, as you talked about earlier, Sarah, and involving them in kind of that clinical governance kind of forum within either the IHAs or the regions or nationally. So I'm talking about, you know, the huge influence that local authorities have on health, the huge influence that NGOs have in health, for example. And then it's about then how do we empower kind of the clinical people that we have, because we all know they have capability to lead, but do they have the capacity and do they have the confidence, you know? So I think it is about diversifying that leadership as well across all the professions. And again, as I talked about earlier on, critical to have kind of the people who are using the service in that kind of clinical governance kind of forums as well, kind of in the IHAs and the regions.
Yeah,
okay, that's great, Tony. Yeah.
Yeah, from my perspective, I think there's a couple of opportunities. I mean, there's a couple of things that we've gotten right. So the Department of Public Health for the West and the Northwest is now part of the regional management team. The Director of Public Health is on the management team, and so straight away, you know, that remit is part of the regional remit, you know, to deliver on population health, and of course the supports and the expertise that come with the Department of Public Health will help us and assist us in all of that as well. So that's really important. But the other great opportunity I think that arises under the new structures is general practice. So you know, the separation between general practice, I suppose, and the statutory health services has been a difficult one to bridge in the past. I think the new structures integrate general practice much more effectively, and I think that will also help us in taking a population health approach to our work overall. So, you know, general practitioners, for example, are integrated at the community healthcare network levels. And we've got clearly identified general practice leaders now across our regions, and in particular in our own region. And I think that'll be a real asset going forward as well for this.
Yeah, thanks, Tony. I loved there, Emer, the way you highlighted capability, capacity, and confidence. I think was your last C there, and it kind of leads me. And I'll stick with you, Tony, for a minute on this question. But you know, you highlight the new people that are involved at the leadership team level. In other words, we've now created a governance structure where those groupings can come together in new ways. If we were to kind of dig right through the system and indeed beyond the system, as has been a topic of conversation, can you identify from your perspective the particular, you know, skills that we need in the workforce, particularly new skills that will be important for as the regions embed and emerge and people begin to kind of get their head around it a little bit more?
Yeah, so I suppose first of all, I think that that there is a kind of a cultural shift that still needs to happen. Now, it's not that we haven't started; we have started, but I do think that there's a significant further progress still required from a cultural point of view. So, prior to the 1st of March, my working life was on the hospital side by and large for 5 years before that, and within the hospitals, we tend, as Emer described a little bit earlier on, we tend to see patients as from when they come in the door to when they go out the door, and do our best for them in that context and let them off on their way. But the cultural shift that has to happen, it has started happening, is to see, you know, how what we're doing within the hospitals, how that's contributing to the overall health of the population. One of our clinical directors is a cardiologist, and it's a department that has really demonstrated how you can embrace that they're not just you know, stenting the patient that comes in the door and then sending them out and off they go, but they're also very focused on ensuring that the health of their population, from a cardiology point of view, is improving as well, and it has done since then over the last number of years. So I think that cultural shift is definitely part of it. In terms of the skills, I think the key skill that I think we're going to struggle with is about how we engage with the people who use our services, how we engage with patients in an effective way. So it's not just tokenistic, and that it does really help us all to arrive at a position where the outcomes that we all want, the people who use our services and the outcomes they want, that they're agreed and they're clear and they're working towards that. I think that's a tough nut to crack. It takes a particular skill set that I don't think was well developed yet within the public health services.
Yeah, thanks, Tony. And Emer, if I could, I think that what Tony is saying feeds to my point in the slide about population health literacy, and just that sense of, do we all know what we're talking about? And if I'm honest, I don't think we do. And I suppose just, yes, the public, but in terms of that skill building from your perspective, maybe a little bit more clinical, who do you think, need, are like in prime or pole position to develop those skills and could really benefit from more of the technical understanding in a for the general population of what population health means?
Yeah, I mean, I suppose, Sarah, I think that this is something that everybody who works in the healthcare system needs to be kind of literate in, to be honest, and as I alluded to kind of in the opening question, while people kind of intuitively think that they understand and know what it means, I think the actual science and the implementation of it, is a very different. So that's why I think kind of, programs such as like this from the RCSI is very, very welcome. I know when I saw a survey on Twitter about this, maybe it was a scoping survey, and it immediately resonated with me as, in the survey as something addressing a lot of the things that I didn't actually know about that I think I do need to know about in terms of kind of either as a clinician going forwards or in a leadership role going forward. So it is about programs, but I suppose what we really need to do is be embedding this in, at this, going from this, but this needs to be embedded really at all levels kind of in education in terms of like, the undergraduate kind of like schools of nursing, medical schools, physiotherapy schools, anybody who's working in the healthcare service, that this becomes part of the core curriculum in terms of education, kind of the workforce going forwards, so there is kind of, I know there's a long way to go in terms of that yet, but I do think that's kind of really the focus that there needs to be on that. And certainly there's a lot of emphasis, even within the current system, and certainly the ECC program has been a key lever in that, and really kind of putting that interdisciplinary working and kind of the education and upskilling of the workforce. So there's an awful lot of work going on around that, and like in Tony's kind of region there, there were really kind of leaders in setting up kind of a lot of kind of the work around that interdisciplinary care. So it is about going into those kind of local pockets of best practice and actually kind of bringing the education to, to the teams locally. So I think there is going to have to be leaders in this, and the public, as Tony says, public health are now kind of embedded and fundamental kind of in the regional structures, but how we bring that knowledge and skills kind of from, let's say, a master's program or a modular program such as this, and bring it locally so that the teams can apply it, so I think there's going to have to be that kind of level of kind of engagement through the regions as well, and that's where the clinical leadership is really going to come in and kind of bringing that to people locally on the ground as well.
Yeah, that's very helpful, Emer. And what I'm going to do is I'm going to slightly pivot the conversation. We're obviously talking today in the context of a School of Population Health at RCSI, and I suppose part of what we do is research and generate evidence, and we're I suppose in the business of making the connections that Ed was talking about earlier between policy and practice and that evidence base that would inform both, obviously clinical decision making, but also that lever of policy and systems, as Ed highlighted. And in terms of maybe going back to Tony, what you were saying about measures and outcomes, how best can we ensure that the evidence and the policy and practice kind of connect and link up in impactful ways?
So that's not easy, to be honest with you,
No.
Sarah. But actually, it's really important, and you know, the role of research in, I suppose, in helping us to bring policymakers along with us on this journey. If you think about it, you know, on a day like today, you know, there's you know, people will be very exercised about the numbers of patients waiting admission on trolleys this morning. Even though it's not the worst morning that we've ever had, it's bad enough, you know. But that's where the energy, that's where the focus is right now. And that can become a daily obsession, and you know, and then it absorbs all the energy at the service. So how do we get policymakers to see beyond what's happening today, and even what's happening just beyond what's happening this year, and to buy into something that possibly goes beyond election cycles and other things that are important to policymakers as well, you know, so that they can also buy into that. And for me, the answer to that question is absolutely in research. It is, by all means, it is by pointing to the good research that has taken place in other jurisdictions and the good experiences from there, but also making that research relevant here in Ireland, so we can start to demonstrate and to build confidence amongst policymakers around that what we are doing, even if it will pay dividends over 5 years or over relatively long horizons, that they are the right thing to do. And I think that's where the you know, good research and good research bases and so on would really help us.
Yeah, and Emer, if I can just kind of come to you with the same question and maybe just push it slightly onwards in terms of, insofar, and I might need to come back to you, Tony, on this, but insofar as you're aware, what are the practical ways in which that research is going to feed into that key decision making as we move forward in this population health approach, whether through regions or whatever other mechanisms that we're employing?
Yeah, actually, I feel really kind of quite strongly about research in this, in relation to this, Sarah. As you know, we've had conversations now. I'm not an academic at all, but I really realise the benefits of research. What I would really, really like to see, I think heretofore in the health system, that we have implemented like services and pathways without really ever kind of evaluating kind of either the impact or benefit on patients or the people who work in the system, or the impact on it, you know, and they tend then just to kind of continue on, you know, and we're never kind of brave enough to say, let's evaluate and stop, or let's evaluate and scale up. And, you know, I think kind of like where we are now in the healthcare system, it's such kind of a critical role, because we are the first country in the world to implement an integrated healthcare system, which is just a phenomenal achievement for Ireland. And like, we're doing all the right things from a policy perspective, you know, the population health approach, all the evidence says that, integrated care delivery, all the evidence says that. But I think what we really, really benefit, what should be fundamental actually, is almost embedded research from the very start in the regions, that you have with everything that's being developed, that you almost have live research going alongside it, so that you can learn and evaluate as you're going on, to actually be dynamic and be agile. So you can say, listen, that approach hasn't worked here, so let's actually just change or stop and take a different approach now. Because what's happened before is that when this happens, it's often too late to actually go back and then reverse what's been implemented. So I think that would be really, really critical, you know, in terms of, you know, being successful at the end of this, being successful at the end of 5 years, 10 years, 30 years, it is to have the research to inform the agility and the flexibility of the service going forwards. And I think unless we have that, it's going to be kind of challenging, you know, because you're almost doing it blindly, because no country has ever done it before. So we are the first to kind of almost test this kind of approach. So we have a huge opportunity here to be kind of world leaders actually in this. So that's what I would, if I was to have, like, somebody put in a question, what would you like one thing for a non-academic, for me, that would be the critical thing, to have that kind of embedded kind of live research kind of going alongside the work that's happening.
Emer, you're singing my song. With a background in organizational and systems learning, I absolutely am delighted to hear you saying that, and hence some of my questions in my slide. And I think you're right. I think embeddedness, I love the idea of the live kind of methodologies where we actually can actively unlearn and learn as we go along. Tony, just finally on this section of our webinar, just quickly to yourself, in terms of that practical action in your own region that is going to ensure a kind of an evidence to practice loop that's lively and embedded, as Emer describes, what structure have you got in place currently?
Yeah, so we actually, even before the new regional health areas, even before the 1st of March when I was appointed, we've been working very closely with our Department of Public Health. Again, we're fortunate in some ways because of our location and because of our setup, and that there has been a kind of a strong connection between a number of the various arms of the health service, including community service, the hospital service, and public health as well as part of that. So we have already been working with our Department of Public Health around researching some of the changes in the way we've been delivering services across the region.
Yeah.
I would say there's a lot of work for us still to do on that front, and embedding it as a way of working. When we introduce a new service, particularly significant shifts like we've been implementing over the last 5 years, embedding research at the outset and learning as we go, I think it's a really important thing that we just haven't been doing enough of.
Brilliant. Thank you both. So what I'm going to do now is we're going to sort of shift the focus a little bit. Ricardo is just going to give you a little bit of background on the course that we are offering in this space, but we are then going to give a little bit of time to some questions from yourselves who are attending the webinar. So please put them in the chat. And we'll have a few minutes at the end just to kind of field a few questions back and forth before we finish at 1 o'clock. So Ricardo, over to you, and thanks again to Tony and Emer so far.
Thank you so much. I think, it's very valuable, these discussions, and hopefully we can have more discussions like these in the future. Thank you so much to the speakers. So now in this final section of our webinar, I will briefly provide some information on the university and on the MSc Population Health Leadership Program, which is pretty much related with today's topic of discussion. But firstly, let me set the scene and let me tell you a little bit about our university. So RCSI is known for its excellence in education, research, and clinical practice. As one of the few universities globally with a singular health focus, RCSI is in a unique position to be able to support professionals throughout their entire careers. Our strong ties to clinical settings ensure our courses are built on real-world experience, ensuring they are always relevant and practical as well. Our involvement in groundbreaking research ensures that our courses and programs are built on the latest advancements that embrace technology and innovation and meet the demands of the modern world. Ultimately, choosing RCSI means investing in an education that equips you with the skills, the knowledge, the networks needed to thrive in your career and make a positive impact on society. Our programs are delivered across a variety of subject areas aligned with identified needs in services and the healthcare system. And as you can see on the slide, our courses are all accredited by the National University of Ireland, giving them that national and also international trust mark in education. We believe, therefore, that our drive to deliver quality is reflected in the global rankings. We were awarded University of the Year for Student Engagement by the Times Good University Guide in 2022. In 2022, we won the Aspire Awards for Excellence in Student Engagement, and we are number 5 in the world for good health and well-being in the Times Higher Education University Impact Rankings in 2024. But what really sets us apart is that we are truly a global university. We have students from 101 countries and 4 international operations across Ireland, Bahrain, Malaysia, and also Dubai. So now, having stated all of these interesting facts about our school, it's also important to touch on online learning. As with many of our postgraduate offerings, the Population Health Leadership Program is delivered online. It's part-time to ensure an accessible and flexible learning experience for those with busy and complex schedules. We understand how important this can be for you and for healthcare professionals in general, as you tend to have very busy schedules, not to mention other personal commitments that we also need to take into consideration. Our priority at all times is to be aligned with your needs and with the students' needs in general. To ensure our online programs are aligned with students' needs, we offer excellence in 4 key areas that you can see on the slide. Our online programs are interactive and engaging, offering students a safe and stimulating learning environment throughout their studies. We also deliver innovative, leading-edge programs which take a keen focus on topical areas to increase specialist knowledge. One of those cases is actually our Population Health Leadership Program. Our rich content explores the most current knowledge and practice. And again, a good example is the Population Health Leadership Program. The course is very up to date with the most recent developments in the area of population health. And while online learning might be a new experience for some, our online learning platform is intuitive, accessible, and easy to navigate, delivering a seamless student experience. Our experienced team have the skills and technology to provide a rich, engaging online learning experience and to support and guide new students, no matter their level of technical ability. At the start of your course, for instance, and this is just an example, a program coordinator will be available to guide you. And in addition, on the learning platform, students also have orientation videos. In essence, what we try to do is we try to offer you the best of both worlds. And here on these slides, you can see some of the courses that we offer online. So as mentioned previously, many of our topical subject areas are delivered online to maximize convenience. These subject areas range from healthcare management, leadership and innovation, quality and safety, clinical leadership, digital health, neurology and gerontology, professionalism and health professions education, to only mention a few of them. Our awards at postgraduate level include masters, diplomas, but also certificates, and we also offer a range of CPD courses online. Our programs are suitable for a wide range of healthcare professionals. And finally, the slide that probably you were expecting. So this slide is on population health leadership on the new program that we will be launching. First of all, I would like to get your attention to the QR code at the bottom of the slide. You can scan it if you want to get more information on the program. There's a lot of information on the website. Essentially, the MSc in Population Health Leadership is one of the newest to our suite of programs. We are very excited to be launching this program in response to an acute needs and a new era of challenge for those working or interested in population health. The course has been designed to deliver highly skilled professionals in population health. Graduates will have a broad comprehension of population health science and leadership with the ability to leverage critical understanding, decision-making, and applied actions to inform policy, systems design, and practices, and drive change for positive population health outcomes. This MSc is delivered over 2 years. It's part-time and it's also completed online. So from a week to week, there will be pre-recorded lectures, interactive activities, and reading materials, along with one interactive live session per week. We also have shorter awards available on this program, whereby students could choose to do PG Cert and a PG Diploma. These options can be completed without further progression, or students could start, for example, with a smaller awards, for example, the PG Cert, and then build on from there to get the full MSc qualification. And as a final note, this program starts in September. Each year, and applications are welcome from healthcare professionals with an interest in this area. We really encourage everyone to send a copy of your CV. If you are interested, we can have a discussion, a more detailed discussion offline, and we can provide more details later. Okay, so I'm conscious of time. We have maybe around 10 minutes left now. And with the remaining time, we will be happy to answer any questions that are coming through the chat. So I'll be keeping an eye. I'll give you a few seconds as well if you want to send us more questions. And then we'll be asking those questions very soon. Okay, thank you so much. So I think we have some questions already. So The first question, so what does population health leadership mean to the panel? And what qualities do they think excellent population health leaders would demonstrate? And I guess this can be to any one of you. Maybe Sarah, you can answer that question.
Well, thanks, Ricardo. I hope you can hear me okay.
Yes,
great,
yes.
thank you.
Perfect.
So yeah, I see all the questions and we've plenty of them. So I think maybe I'd direct that question because there's quite a few questions here for Tony as well. I'll just prepare you in advance, but maybe I'll direct that question to you, Emer, for a start. What do you think the qualities of an excellent population health leader would be?
Like, I do think, you know, it's not, I think it's kind of, it's broader than population health. It's that clinical leadership, you know, that I kind of believe in terms of in delivering on the population health agenda, you know, and I think Tony alluded to it earlier, you know, there is a huge kind of cultural kind of, you know, change needed kind of within our system. And, you know, we can't really underestimate kind of like what people need and want from that. And when I mean that, I mean the staff that we're working with and, you know, undergoing this huge transformation then on top of everything else that all our healthcare workers have gone through. So I think there's a huge part in attending to the culture. And I think the leadership will really need to, you know, if you were kind of to pick one priority as a leader, whether kind of from Tony's position or a clinical position, it would be kind of addressing and understanding the culture and what kind of our healthcare workers need and want, you know, and prioritising kind of their needs and what they want kind of from the system. And I think that's going to be a huge part. And then I think kind of critical then in that leadership now in terms of the new landscape of healthcare delivery will be to, you know, to have the knowledge and skills around what integrated care is and around what population health is, because I wasn't trained in it and a lot of people I know who work with weren't trained in it. So I do think that we're going to need to have those skills and, you know, going forward in terms of delivering. And we are very fortunate, you know, in that there is really a public health structure now kind of throughout kind of nationally and throughout the regions, you know, and I think kind of there's one of the questions there. I think kind of relationships with public health have been enhanced really with the pandemic and a real understanding kind of the, you know, the broad remit of their role. So in every region now there's a kind of a healthcare, you know, there's a health service and a health improvement kind of public health role and also, you know, a health intelligence role. So these are all things that, you know, can really kind of support leaders to lead, but also kind of for leaders to kind of lean into in terms of kind of like addressing kind of like all what we need to in the regions.
Yeah, thanks, Emer. And we really do have a lot of questions here, which is interesting, and we will maybe kind of pop them in the chat. But Tony, just to kind of hone in, and one of them is with the night time, how does the public-private eligibility-based delivery landscape come into the consideration of the new REO leaders? Just a question there that is interesting.
I think it's a really important issue, and it is shifting. It's something that's changing right now. So I think for many of us, well, certainly people of my age, we've grown up in a system that is balanced between public and private, and you know, we see it in our hospitals. So there's a mix of public and private practice in our hospitals. We see it in general practice as well, but that's shifting and changing, and those changes have been kind of a little bit incremental, so people mightn't have noticed. So the expansion of eligibility for free GP care and so on over the last few years, the last few budgets in particular, I think has helped move us along that pathway. Of course, we still have a long way to go on that front, but I think that has certainly helped. And the funding that has gone into general practice as well around chronic disease management as part of their contract, I think has been helpful in that regard as well. You know, public funding going in to support that. On the hospital side, or on the consultant side, maybe more so than the hospital side, we have the new public only consultants contract in place since March of last year. That's March 2023. And of course, we're starting to see that take effect now with regard to private practice. So for existing consultants that signed up to that contract, they're working through their exit from private practice in the public facilities. So it'll be interesting to see how that works out and how that transpires. So, you know, certainly purely from a financial point of view, it means that you know, that income that would come to the hospital as well as to the consultants, but to the hospitals as well, and that won't be there, and that's now being replaced by public monies. And so our public facilities are moving slowly but incrementally over towards public only. I have to say, from my perspective as a public servant, as a as an REO, I think that's a very positive aspect of Sláinte Care. A move towards a single tier health service, I think, is really important, and it will also facilitate a public health approach to the delivery of care.
Thank you. And I'm just noticing there, I mean, I think was one of the questions there are how could the design user, let me just get the question exactly here, the user-centered design approaches. So I think there's a question there around kind of new levels of partnership as well. I mean, we have talked quite a bit in the seminar around the need to bring in, other actors. Emer, in terms of that kind of user-centered design approach, I think it's key in what you were saying in terms of the embedded idea.
Yeah, no, absolutely. And certainly when you look at the new structures or the proposed new structures in the region, it is about having that, a very high up level, even reporting into the CEO of the HSE and also into the regions, that public patient kind of involvement that, there's kind of like a direct reporting and line in there in terms of incorporating them into the design of the structure, so like there's various kind of methodologies about, how you'd include, but I think, what's equally as important is, in having that kind of as part really of the leadership team, but also I think it's really important that we need to learn how to support people to kind of be involved in the design who haven't kind of been trained in any kind of healthcare sphere. So I think that's a really critical point in that how we support the people who are going to be involved in this, because it's probably going to be one of the more important roles, and so I think that's going to be really important and what that will look like going forwards.
Yeah, okay. And look, there are a good few questions there around, common measures, regional kind of different patterns and inequities, partnership levels, and we haven't got time to go into them in detail, but I do want to pick up on, Tony, there's a lot going on for the workforce at the moment, and, how are people currently learning? I'm aware that there's a webinar next week, is that right?
Yeah, there's a webinar next week, HC webinar, I think it's on the 27th, so I think that'll be a useful opportunity for our own staff working within the HSE to contribute to, I suppose, this discussion in some ways, and contribute to how we roll out the population health approach across the new regions. We're fortunate in that even though we've started rolling out the regions, there's still a lot that has to be decided, a lot that can still be shaped and influenced, and so those workshops are aimed at giving people the opportunity to do that.
Fantastic. And listen, in the spirit of our partnership and, the amount of people who are gathered on this call and the importance, we will put the details into the chat for that webinar, which is at 2:00 next week, HSE led, and delighted to do that. And just with my eye on the clock, Emer, I'm going to throw you a bit of a put you on the spot question. You mentioned when we were preparing for today that you might be interested in registering for our new MSc. So what will you register, and what skills will you be looking to build? I think you've already said it, but maybe as a finish out.
Yeah, no, I'll definitely be registering. I'm hoping I might get some bonus marks for participating in this webinar here. So I'm not going to fail my first module. No, as I say, when I read the survey first and when I read the description of the thing, it's, for me as a clinician and as a current kind of leader in the system, I really believe that there is a lot there that I can learn to incorporate kind of into my role going forward. I think there is a deficit in my knowledge and skills in terms of population health and what I need to know and learn about it. I suppose I think the more kind of experience and the more kind of like senior I get as a clinician or whatever, I actually kind of recognize the more that I actually don't know. So maybe that's just a natural kind of evolution of clinicians as you kind of like merge through the system. But I do think this is really critical. I think any knowledge and skills that anybody will have would certainly help in your clinical practice, whether individually or with a patient on a day-to-day level. And then ultimately it's the aspiration that we're going to be living in a healthier country, where everyone will thrive kind of going forwards.
Okay, thanks a million, Emer. And I just, without further ado, I've noticed there's a good few questions, so we might do, as the session is recorded and will be shared, we might do a little prese of the questions as a kind of food for thought. And sorry, I couldn't get to them all. But just to say, from our perspective in the school, huge thanks to both Emer and Tony, who've given us an hour and a half of their precious time. Very busy responsibilities that they both carry. But I think we would all agree that definitely, key pivotal leaders in this space as we go forward, and we really appreciate your insights. And thank you also to Ed for kicking us off this afternoon, and particularly to the technical team in RCSI. Just for my part, I want to say many thanks, and thank you to all of you who have attended. We've had fantastic attendance, and we look forward to continuing this conversation. We're actually only at the beginning of a conversation and not at the end. So thank you, everybody.
Thanks, Sarah.
Thank you so much, Sarah, and thank you to all speakers and to those that joined us today. It was a pleasure. We really hope to have more discussions like these in the future. And as a final note, if any attendees are interested in pursuing postgraduate education at RCSI, we really encourage you to scan the QR code to learn more about our Population Health Leadership Program, and just get in touch with us. We will be happy to help you and to provide more information if required. Okay, so thank you once again to everyone involved, and thank you, Ash, as well for your help with everything. Thank you.